have the pleasure now of introducing Professor Takeuchi. He's a professor and chairman in the Department of Hamamatsu, University School of Medicine. His special interest is in the clinical investigation of upper GI surgery and in molecular analysis of GI cancer. His presentation today for 15 minutes is on minimally invasive, function-preserving gastrectomy based on sentinel node concept in gastric cancer. Professor Takeuchi, the floor is yours.
Thank you, Chairman. It's my great pleasure to be here. And first of all, I'd like to thank all of you for giving me this wonderful opportunity on my presentation here today. But actually, I have 4 presentations today, so I try to do my best. My first topic is minimally invasive function-preserving gastrectomy based on sentinel concept in gastric cancer. My talk is relatively special because, incidence of early gastric cancer is very high in Japan. So Japanese health check system can enable us to find gastric cancer in very early stage. That's why I am doing this. I'm doing sentinel mapping especially for early gastric cancer. So, as a background, as you know, the laparoscopic gastrectomy is very useful and beneficial in terms of cosmetic benefit and less pain and reduced inflammatory response and a faster, hospital stay. But what about late phase, patient QOL? Even in laparoscopic surgery, we try to do distal gastrectomy or subtotal or total gastrectomy as a standard procedure according to the Japanese guideline. But as Professor Hiki presented, after the standard gastrectomy, body weight loss is quite remarkable, such as distal gastrectomy, minus 5.3%, and total gastrectomy, about 10% body weight loss in Prospective Trial. So it affects, late phase patient QOL, as Professor Hiki presented. Actually, in Japan, as I told you, incidence of early gastric cancer is quite high. Actually, even in T1B cancer, incidence of lymph node metastasis is only 15%. So residual 85% have no lymph node metastasis. But we still have to do, distal gastrectomy or total gastrectomy. So if we can do a more accurate and efficient diagnosis of staging of lymph node metastasis, we can minimize the extent of gastrectomy, especially for early gastric cancer. So sentinel node biopsy and mapping is already applied in the melanoma breast cancer surgery in clinical practice, probably in your country. So we have been applying this sentinel concept for treatment of early gastric cancer surgery. So as a tracer of sentinel mapping in gastric cancer, we have been applying the 2 tracers. One is radioisotope, technetium-tinchroid. We usually inject this radioisotope tracer the day before surgery using endoscopy into the submucosal layer surrounding the primary tumor. And also, at the beginning of surgery, I inject blue dye such as lymphozyrin or indocyanine gene into the submucosal layer using endoscopy in a similar manner. So even in the laparoscopic surgery, you can see afferent lymphatic vessel and a sentinel node very clearly. And also, handheld gamma probe is very useful to identify the sentinel node accurately. So we reject the sentinel node and identify the sentinel node on the background and serve to the intraoperative pathological diagnosis. And if sentinel node are negative for cancer metastasis, we can minimize the extent of lymphadenectomy. So that's my concept. So I'm sorry for a busy slide, but there are more than 100 papers reported worldwide about the sentinel mapping in gastric cancer. In general, sentinel detection rate is 90 to 100%, and overall accuracy to predict the lymph node metastasis is 85 to 100%. That's a very good, excellent results, almost equivalent to melanoma or breast cancer sentinel mapping. So in Japan, a multi-center prospective validate study has been performed. It's already finished. They evaluate, evaluate the sentinel mapping in gastric cancer. The primary endpoint of the study is the sensitivity to detect the metastasis based on the sentinel status. So the subject of the study is clinical T1N0M0 or T2N0M0, a relatively early gastric cancer, tumor diameter less than 4 centimeters. So in this study, 397 patients underwent the sentinel mapping, and subsequently followed by a standard gastrectomy to evaluate the accuracy of sentinel mapping. So this is a summary of the results of sentinel biopsy in the study. So detection rate of sentinel node is 97.4%, and identified number of sentinel node per case is 5.5, and the sensitivity to predict the metastasis is 93%, and the overall accuracy based on the sentinel concept in this study is 99%. That's a very excellent study. So more recently, ICZ indocyanine reinflorescence imaging appeared attractively. So it enabled us to, visualize tiny lymphatic vessel and a sentinel node more clearly. So based on the previous multi-center trial, we have been applying this technique for individualized minimally invasive gastrectomy. So clinical T1N0M0 less than 4 centimeters. We initially performed the laparoscopic sentinel lymphatic basin dissection, and according to the results of intraoperative diagnosis of sentinel node, if the sentinel node are positive for cancer metastasis, we do a laparoscopic D2 gastrectomy, total or distal gastrectomy. But in case with the sentinel node are all negative for cancer metastasis, we can do a laparoscopic function-preserving gastrectomy, such as wedge resection, partial resection, or segmental or limited proximal gastrectomy. So this is an example. If the sentinel are negative for cancer metastasis, we can do a wedge resection of the primary tumor or a segmental gastrectomy. Or this is a schema of the partial gastrectomy with sentinel biopsy. So sentinel, if the sentinel are negative for cancer metastasis, at least we recommend the sentinel basin, this lymphatic basin resection for safety net of the creativity. But the primary tumor could be treated with partial resection instead of the distal or total gastrectomy. So more recently, laparoscopic endoscopic cooperative surgery that's originally developed by Professor Hickey in 2008, but we modified this technique, this non-exposed endoscopic wall inversion surgery named NEWS. We combined this technique with sentinel node biopsy to perform the minimize the extent of gastrectomy. So if the sentinel are all negative for cancer metastasis, this primary tumor can be treated with the NEWS. I'll show you this video in the next presentation. So this is a preoperative view, early stage gastric cancer in the middle of the stomach. And after the surgery, just you can see a scar of the resection after the resection of the primary tumor. But this patient retained a very good function and the QOL of the stomach even after the surgery. So we are now evaluating this surgical procedure by multi-center prospective trial. Especially, we try to evaluate postoperative survival in patients with a minimized gastrectomy with central basin dissection, in case with central node negative cancer metastasis. And also, we try to evaluate the patient of the postoperative QOL of the patient after this kind of minimized surgery. In South Korea, randomized control trial, which compared laparoscopic standard gastrectomy with minimized gastrectomy with central mapping. It's ongoing. So this study also expected. Probably these studies will revolutionize the future of the gastrectomy in patients with gastric cancer. This is a summary and a conclusion. Central concepts for early gastric cancer could be validated, and multi-center trial has established the standard procedure of the central mapping for especially early gastric cancer. So modified gastrectomy with individualized minimally invasive surgery based on central concept, which might retain the patient QOL, should be established as the next surgical challenge, but it should be carefully evaluated. Thank you for kind attention.
Thank you, Professor Takeuchi, for this elegant presentation. Any questions? Please.
Thank you very much. I would like to ask you if you compare central node mapping with the regular dissection of B2 and see the difference of the outcome. Would it be different or it's the same?
Okay, that's a very important question. Now we are evaluating the long-term survival of the patient who underwent such a minimized gastrectomy with central node negative patient. So I cannot say, I cannot answer the question at this moment, but in your future, I try to verify the long-term survival of the patient with a minimized gastrectomy compared to the standard due to gastrectomy.
Next question.
Sorry, I have one comment and one question. First, early gastric or central lymph node mapping, it's only done in early gastric cancer. In Saudi Arabia, it's very, very rare to see early gastric cancer. So the experience of central lymph node, it will be very poor in our country. Yes, we have senior of upper GI and surgeon, but I think this is very important. You have done more than 390 or 360 cases of early gastric cancer for central lymph node. That means that they are not, part of the AMR or SD. My question is how is the quality of life for those patients? So what is the patient benefit for the surgery? Segmental gastrectomy, still under debate, is not so at the end you will have the same. So what's the difference between segmental gastrectomy with central lymph node? So if there is negative central lymph node, you will do segmental gastrectomy. So what is the patient safety and quality of life different in that patient?
Yes, that's also a very good question. Many Japanese gastric surgeons try to prove the postoperative QOL of the patient with minimized gastrectomy, such as PPG, porous preserving gastrectomy, or proximal gastrectomy, compared to the distal or total gastrectomy. But actually, probably almost no study in the prospective study. No prospective study. So, as I told you, in this prospective study, we also try to evaluate the postoperative QOL. So, probably next time, when I will come here, I can answer the question. Thank you.
Can I have a question? Yeah. If you have the positive by ICG, what is the positivity by histopathology in your cases?
You mean the...
How accurate ICG?
ICG compared to the radioisotope?
No, the histopathology.
Actually, yes, that's also a very good question. We employ the dual tracer method, combination of radioisotope and ICG, because ICG is very good tracer because we can visualize the lymphatic flow directly intraoperatively. But the problem is, too fast, very spread to the second or third or fourth lymph node. It's spread very fast. And on the other hand, radioisotope tracer, it's invisible, but more accurate diagnosis is, is performed in the radioisotope tracer. So at this moment, ICG is not superior to the accuracy of the radioisotope tracer, but in near future, ICG fluorescence imaging, it's much better in terms of the diagnosis of the central node, even in the fat-dense tissue. Yes, in some cases, in the fat tissue, ICG is not clearly visible in the normal light laparoscopy. But if you use ICG fluorescence imaging, probably the accuracy will be improved much better than now.